This is the summary of heart failure drugs. Heart failure is when the heart is not filling or pumping enough blood. It is like a car with a weak engine but still running. So what we are going to do is we are giving some drugs to increase the performance of the heart. Okay, so that's how these drugs work. If anybody asking you to distinguish, of course, and anti-anginal, anti-arrhythmic, all those drugs are entirely different from heart failure drugs. Okay, we are going to look at the uniqueness of these drugs. Okay, so why do you need these drugs and why these drugs are effective? Simple answer is, when a heart is failing, it will activate compensatory mechanisms like a renin, angiotensin, aldosterone system, that is RAS, and sympathetic nervous system. This will result in increased heart rate, vasodilation, increased blood pressure, etc. Right? So we use these classes of drugs to regulate. Most of them are combination therapy. So a recent recommendation is 4 pillars of heart failure drugs, including ARNI, one of the classes, then the second one, BET blockers, then SGLT2 inhibitors, and mineralocorticoid receptor antagonists, or also called aldosterone receptor antagonists. These are 2 of the steroid potassium sparing diuretics. Okay, we will go through all those. Let's have a big picture, right? Out of all these, of course, I will break down in the next slide, but just bear with me, okay? I want you to remember 2 terms: acute heart failure and chronic. Okay, that means the patients take it, they can take a longer term oral pills. We have a lot of drugs in the list. But if a patient is coming in the emergency department for the acute heart failure, you need to work really quick, right? So you need to provide supportive oxygen. Then diuretics are the central for treating that, especially loop diuretic furosemide. In that case, of course, you will give nitroglycerin to avoid chest pain. But one drug in all these heart failure drugs, one of the classes, beta 1 agonist, that is called dobutamine. So I remember like that, but I am in eerie cold extremities. Usually for cardiac shock conditions, my extremities will be like very cold, and different conditions like edema. It's called wet and cold conditions. That means wet means too much water in the body, because heart is not pumping well. It cannot remove enough fluid, right? Circulate enough fluid. That's why people get that cold extremity. This time, it's like a breaking down of my car. I need to call 911, right, for the heart failure. So quickly, IV drug, we can do that. So we're going to discuss that drug. Of course, I want you to remember, distinguish that drug from all the other drug. Instead of dopamine, this drug is very effective. We will talk about that, the reasons in future. Okay. And another point, diuretics is very central for acute heart failure, but for the chronic heart failure, usually that will be given only as supportive therapy. Okay, if you are wondering. Another point before we start, ACE inhibitors and ARBs we were talking about giving for hypertensive conditions, right? We were talking about. But in heart failure, we will never combine this drug. It has to be either ACE inhibitor or ARBs. But why did I put it at the end, these 2 classes? Recent evidence-based clinical studies proved that better outcome with a ARNI, this class of drug, compared to the ARBs or ACE inhibitors. Therefore, we are starting with the ARNI first. Okay, first class of drug, angiotensin receptor neprilysin inhibitor. Okay, so before I start that one, let's talk about with a story so that you will remember easily. This is how I remember, right? All the general heart failure drug. ARNI is the best, very effective. Of course, combination drugs, but ARNI is very effective. You can give to patients with a patient if cannot tolerate even the ACE inhibitors, we can give. But generally, most of the patients can take this drug without any problem. Sacubitril, and valsartan combination. How I remember is we are all going for a party. So generally, everybody can take this drug with a heart failure. Good. But I am going with one of my African American friend and a 70-year-old grandma. Okay, the next two class. Vasodilators, hydralazine and isosorbide. Those are two drugs. They are given as combination. These drugs are very good in patients who cannot tolerate ANI, or even you can add it as an add-on therapy, right? You cannot control that effect. You cannot get enough compensatory effect. You can add this drug, or if these patients cannot tolerate those drugs, you can take this hydralazine and isosorbate. I will tell you the reason, especially why this is good for certain group of people. We will talk about that. And the next one, I told you, I am going to my grandma. Nanny is coming with me, Nanny Ebivo. She is 70-year-old. So recent, like a senior trial showed that nebivolol is a beta 1 blocker that is very effective in heart failure in patients with especially 70-year or older. If you compared this with a later drug digoxin, this drug can improve like a less mortality rate. Okay, keep in mind that is a very good thing about recent studies. And the next one, we were going on the way, my car broke down. Similarly, I was talking about right here. Here, it is not blocker, it is agonist. Beta agonist dobutamine we can give as quick, like 911, like IV drug. Okay, everything is done. Okay, so now my car has to be towed by the tow truck. So I am going to tow. It's like my heart has to like really, this is the last line drug kinda, right? This is an add-on drug. Digoxin actually helped to make the heart to work hard. Like it's like whipping a horse. Horse cannot carry the heavy cart. Similarly, my heart is so weak, it cannot pump, but it is going to push the heart to pump with the digoxin. We will learn the mechanism. And later, when I returned from the party, I got my friend. She's very funny friend. Her name is Iva. She always walk with a braided hair. That's how I remember. Iva Braidin, funny channel blocker or funny current blocker. Okay. And then I came home. I have another sister, Empa. She steal all the salt and glucose from my sugar and from my kitchen. That's how I remember gliflozin class of drugs, sodium glucose transporter inhibitor, empagliflozin. Refer this drug again in the diuretic class, and also we have potassium sparing diuretic. We already learned, but we will look at it. Okay, let's go through one by one. Okay. First class, ANI, that is sacubitril valsartan. So what is sacubitril? Why can't you just give sacubitril? That's an important point I want you to understand. And mechanism, just study the class name, that's it. So let's look at it. Angiotensin receptor blocker is valsartan. It combined with the neprilysin inhibitor, that is sacubitril. What is that? Easy to understand. Why that is well tolerated and why is it given to heart failure patient? Easy answer. When a heart is suffering and struggling and failing, for instance, heart muscles are so stretched out and with too much pressure, that time it's like tears of the heart. It's like heart is crying. Heart, these dying cells start secreting a lot of natriuretic peptides. These natriuretic peptides is blocked by a villain. It's like a bully. That's an enzyme called neprilysin enzyme. If you can block that enzyme, the heart will start secreting a lot of natriuretic peptide. As soon as this peptide goes, it will give the signal to vasodilate and remove excess water and remove sodium. It's like heart is giving order. Don't listen to anything. We are about to die, so just do it. It's like a real fast action. So that is why scientists proved that dying or heart failure conditions, natriuretic peptides are too high, and that is very helpful for the body to compensate, but that is blocked by this neprilysin enzyme. Therefore, we are going to use an inhibitor to block neprilysin enzyme. That is what called neprilysin inhibitor sacubitril. But neprilysin enzyme also used to usually chop down extra angiotensin 2 in the blood. If you are using an inhibitor to block neprilysin enzyme, you will end up in having so much angiotensin floating around, and it will cause hypertension, blood pressure increased, right? It will affect the AT1 receptor. Therefore, always sacubitril, whenever you combine with the valsartan, another angiotensin receptor blocker, this drug works well. Keep in mind, both these drugs can cause a lot of adverse effect together. You can study together. Hypotension and hyperkalemia will be the adverse effect. Therefore, this drug is usually given with a well monitored by the cardiologist and given with a loop diuretics, okay, low dose of loop diuretics. Anyway, keep in mind, sacubitril, valsartan, mechanism of action, angiotensin receptor, neprilysin inhibitor. Very well. The next one, I was talking about what if this drug is not on, or this is not effective enough. We are going to add vasodilators combination. Why is it combination? Easy peasy. So remember, hydralazine is the drug targeting the arteries. Our arteries are going to dilate, so that hydralazine is effective, and also we are combined with a nitrate. Remember nitroglycerin? Similarly, isosorbate dinitrate, that drug is going to be added with this. This drug will be dilating the veins with nitric oxide production, right? So what happened is, this drug is very effective drug combination, especially the hydralazine is effective in patients with a low RAS activity patients. For instance, like I was talking about some of the African American patients, if they have lower RAS, renin-angiotensin-aldosterone system blocker or anything is not effective, so that you need to give this drug combination. So this drug, hydralazine, have a secondary effect on that added benefit on these patients. Therefore, this is going to be a combination very effective to those kind of patients. If you are asking me why it is important to know that, vasodilators, like I said, hydralazine targeting the arteries, arterial vasodilation, isosorbate targeting the venous vasodilator. Both are different mechanism. Isosorbate by releasing a lot of nitrates. Therefore, this combination also has nitrate adverse effect. Remember that nitrate adverse effect, throbbing headache. Remember, refer the other lecture also, summary also. So about the anti-anginal, so that can be possible for also. And but uniquely, hydralazine combination, hydralazine can cause specific adverse effect. I want you to know that. Reason, this can deposit in the especially in the, it can increase drug-induced lupus, especially in high doses and sometimes in certain populations. Let me tell you the reason. This is unlike chloroquine or doxycycline, okay? That is a different mechanism. Remember, chloroquine used to deposit in the melanin-rich melanocytes, and the doxycycline can influence the keratinocytes in the skin, right? But here, hydralazine used to has a tendency to accumulate or deposit between the dermis and epidermis. That is, it can it's antibody coagulation. Coagulant or the complex, immune complex with the drug can deposit in the junction of dermis and epidermis in patients. That's why it can increase drug-induced lupus. Okay, that's a typical board asked question. You must know. How do you remember? Hydralazine is a small molecule. This acts as a Hampton, and this can bind to the self-regulator proteins and thus producing auto-antibody production. That is the reason it can cause that lupus, drug-induced lupus. But if somebody asked you why this is effective in African American patients, the reason, this can act as an decrease oxidative stress in patients. How is it doing? So let's look at it. So antioxidant effect of hydralazine in some genetic variation conditions, for instance. Adaptation to UV radiation is the increased melanin in the body. When our skin has too much melanin, we will tend to produce less vitamin D. One of the science research group says that. So just remember that. That's an easy one to remember. So when the skin has reduced vitamin D production, vitamin D, keep in mind, that is very essential for your endothelial cell function. Remember, endothelial cells are very much throughout your blood vessels, right? If the endothelial function is not, because vitamin D mediated oxidative stress is too much, because it not enough vitamin D, therefore low vitamin D can increase oxidative stress. Different reasons, some of the genetic factors, others are there. Anyway, hydralazine proved to be effective in patients based on the clinical evidence-based science. Okay, understand? So we are done with that section. And isosorbate also can cause headache. Okay, keep in mind. The next one is beta blockers. Beta blockers, I want it to specifically for heart failure, for angina. I was teaching another drug, like metoprolol, remember? So I am giving only not giving all the drugs in this, so that unique mechanism you will remember. Nebivolol, I want it to study specifically for heart failure drug, because evidence-based, especially the recent trials, trials like studies proved that this is effective in elderly patient, nebivolol. So just remember that one. So how do you distinguish? Because beta 1 blockers, yesterday in the anti-angina drugs we were learning in the other summary, metoprolol succinate was the one we were learning about anti-anginal, right? Of course you can use it for heart failure also, metoprolol, carvedilol, bisoprolol, etc. But I don't want you to overload with that. In anti-arrhythmic drugs, I'm going to give you a couple of drugs, but just study nebivolol. Okay, let's look at that. Why am I specifically said beta 1 blockers? Beta 1 specific drug is very effective for heart failure, because look at that picture. Beta 1 adrenergic receptors are aggregated in the SA node, AV node, and throughout my cardiac muscle, especially in the ventricular cardiomyocyte. Therefore, this is supposed to be stimulated by the sympathetic nervous system, so that I can just beat the heart faster. Heart rate will be high and pump enough blood. Why? Because when I see a lion or cheetah or snake or something, I have to run away from that, right? So I wanted to really pump blood into my muscles, skeletal muscles and the heart, and breathe well. So these are the mechanisms. Sympathetic nervous system will stimulate, increase the heart rate, so that it pump blood into my brain, so that I can think where to run. Does that make sense? So that is the one. If the heart is failing, heart failure, you're supposed to slow down. Oh, here you go. Beta 1 specific blockers, nebivolol, can calm down, slows down, that is block and inhibit SA node action. That means heart rate is lower. AV node actions, it will not conduct enough, not too much conduction to the Purkinje system and the next step, right? Bundle of his, but and to the directly it can bind on to the cardiomyocytes, beta 1 receptors. That's how. What will happen in there? Contractility will be reducing, therefore not too much forceful beat, so that heart will be calming down. Very good. So keep in mind, you may hear about general class adverse effect of this drug is bradycardia. Reason? Yeah, you are directly stop blocking, right? I will teach you in the AV block, in the other beta blockers, in the anti-arrhythmic drugs. I don't want it to confuse too much, because if you are really blocking here in some patients, it will not conduct the the heartbeat from the SA node, that signal from AV node to the ventricle will not be passed. right, through the AV node. That's why it is called heart block. Just don't worry, but I want you to understand we are targeting beta 1 receptors and blocking. What is the end result? It's going to reduce the heart rate, reduce the cardiac contractility, and as a result, it's going to reduce the cardiac output. The heart will get like enough like relaxation. Okay, bradycardia is one of the adverse effect you can remember. Okay, and the next one is just opposite of beta 1 blockers. That's why I specifically mentioned that beta 1 agonist, receptor agonist. That means exactly same picture I want you to remember, like we were blocking with the nebivolol, but here in dobutamine, the patient got a cardiogenic shock. That means the heart is not at all beating. You need to like stimulate. It's like an electric current, right? Dobutamine it's like instead of sympathetic activation, this drug will go and bind into SA node, AV node, and cardiomyocyte B1 beta 1 receptors, so that it will stimulate the heart to beat. Very good. Okay, heart rate will increase and cardiomyocytes will contract enough. Heart will start working again. It's like a 911. I called, I got IV dobutamine, everything good to go. Okay, so the next treatment is, you don't take it for every day. Okay, this medication, this is for emergency. Very good. Why? How do you compare with the why do you prefer this than dopamine? The reason is IV. Reason is this drug is little more milder than dopamine adverse effects, right? This is this will not have too much increased oxygen demand after stimulating the heart compared to the other drug, dopamine. So that's why this is dobutamine. Okay, and the next one is I think I mentioned all the points for more predictable effect than dopamine. That is the another point to remember, because of the pharmacokinetics and all the effect will be better compared to the other drugs. This is an IV drug, quick, very fast action, very short acting drug, very effective. The next one, my car has to be dragged by what is it called, the tow truck. That means I am giving it, my heart is about to like really, it's cannot. I added so many different types of drug, it's still not effective. In that case, we can give a drug, its mechanism is super important. You must know how to distinguish all this. Why? Digoxin is the not going to be prolonging your lifespan. Reason, this is like a last resort agent. But nebivolol proven to be increase your like reduce mortality rate and prolong your life. Okay, keep in mind that distinguishing features. Digoxin, why is it last line? Keep in mind, digoxin is like the heart is trying to pull all this, doing all this hard work, like a horse pulling a heavy carriage or the cart. So because horse is not moving, I am going to whip or beat the horse so that horse will move. So similarly, if I give that last resort drug, because I need to pump, otherwise the body will be like, blood will not circulate. Therefore, digoxin will have a specific transporter blocking that will help to give, like it's like pushing the heart to pump. So where is it working? Look at that target. It will be in the cardiomyocyte. Okay. All the cardiomyocytes have specific transporters called sodium, potassium, ATPase. Okay. ATPase. That's a, okay. Hold on. How I remember is 3-2. That's a mnemonic. Okay. 3-2-1 Nokia digital. That's how I remember. That means 3 sodium NOKIA, sodium NO, sodium out. Usually, normally my heart will throw out 2 sodium out, then 3 sodium, 3-2-1, right? 3 sodium out, 2 potassium in, NOKIA, with the ATP, in the presence of ATP. So that's the mechanism. But when in that time, heart is not, like heart is going to slow down, right? But when you block that that is sodium potassium ATPase with digoxin molecules, this is going to increase the sodium inside the cell, which will in turn stimulate the calcium and start contractility, strong contractility, so that you get more stroke volume. That is how digoxin works. I wanted to compare digoxin with the digitoxin. Digitoxin is, the word it says, digitoxin is toxic. Okay, both these drugs are derived from foxglove plant, but nowadays we don't use this. Digoxin is also, it's about 200-year-old drug, but why do we don't use this drug commonly? Because this is like we have better profile pharmacokinetic drug available, but still sometimes we add it, especially it will work well with the beta blockers, and understand this mechanisms. It also has secondary effect on the sympathetic nervous system also. I want you to understand this mechanism. Same, what is the receptor? That's the same ATPase, that enzyme or ATPase. So that is the one blocked by this drug in eyes also. So hold on. Digoxin adverse effect. Usually it can cause arrhythmia, right? Because if you are trying to push the heart so hard, because already heart is so weak, sometimes it can lead to dysarrhythmias and all the problems, right? That's a major adverse effect in patients. So that's why you are not going to give this drug to every single patient, right? So arrhythmia will be a common adverse effect. Another, like that's a deadly adverse effect. Okay, if I have to say serious adverse effect or life-threatening of digoxin is arrhythmia. But a common adverse effect is patients can get yellowish halo, or it's called a medical condition that is called xanthopsia. That is actually getting yellow colored. They can see more yellow instead of other color, yellow to green color, right? Shade. I'll tell you the reason. Very easy to understand. The same mechanism, blocking of sodium potassium ATPase, will be happening in our eyes, in our eye, retina cone cells. Okay. So this is what important, easy to remember. You may heard about like in 1800, one of the painter, he is a Van Gogh, and he used to paint like a beautiful pictures, but later in his life, he used to start changing the color, and most of his pictures look like greenish yellow color. So he used to have heart failure, and he used to take, his physician used to prescribe digoxin to him. Okay, so people say that maybe that's a reason or maybe not, but that's a good example for you to remember the adverse effect of this drug. Why is it important? Because the next drug also can cause problems related to visual adverse effect, but that is an entirely different mechanism, nothing to do with eye yellow color. That's why I wanted to understand. Why? Very easy. Let me talk about that. So, sodium potassium ATPase in your retina maintain iron gradient, essential for your color vision. This sodium potassium ATPase is fundamentally important for the proper functioning of the cone cells. Okay, in your cone cell, if you wanted to know the details, you have three types, right? That is long wavelength, medium wavelength, and short wavelength. Like long wavelength, red color, medium wavelength, green color, and the short wavelength, blue color. So that's named as L cone, M cone, and S cone. Okay, just understand, L cone and M cone will work simultaneously when you give digoxin. So that red and green combine, like the changes, and this drug can suppress the short wavelength light, blue light. This will end up in giving the brain will perceive everything yellow. That's a real answer if somebody asks you. Okay, anyway, understand simultaneous red and green will be because of that masking, working together with the L and M cones, and whatever the reason, same mechanism, whatever happening in the cardiomyocyte happening exactly in the retina cone cell. That's it. What is the mechanism? Sodium, potassium, ATPase. That's a target. It is blocking. Very good. Sorry. It will block so that it will increase the calcium and making this pumping too hard. But what happened to your retina? In the retina, because of this loss of, they are blocking this sodium, right? So that potassium will be losing. So too much potassium loss inside the retinal cells, that is end up in the change in the color. Okay, so understand that is the real mechanism for the visual retinal cells will be, the cone cells will be having low potassium. That is an indirect effect of the blocking of sodium potassium ATPase. Very good. Okay, let's move on. The next drug is ivabradine, right? So the ivabradine is a IF current blocker, or it is also called inward funny channel, right? Inward current, sodium current can be blocked by this drug. So why is it called funny? Reason, this is a because it is targeting a receptor or the ion channel named HCN ion channel. Nothing but this is working in the SA node, specifically SA node, IF blocker or ivabradine, mainly. Reason, your SA node and AV don't usually function with the IF channel, funny channels, right? So here is what happened. Hyperpolarization activated cyclic nucleotide gated channels. I just want you to remember HCN channels if you can. Otherwise, just remember funny channel. That's enough. So why is it funny? Because normally during the hyperpolarization nothing happens, right? But here the case is hyperpolarization time, the sodium is going to be inwardly moving. That is going to be blocked from inside. It's like plugging the sodium channel from inside. This drug can easily pass through the membrane and get into the cardiomyocyte and blocks the IF or funny channel or funny current. Therefore, this is mechanism is funny current blocker. Drug is ivabradine. I was talking about Iva is my friend with the braided hair. She is very funny. So that's it. So this can prolong the, we will learn that in arrhythmia if all the action potential and all, but just remember the drug's specific mechanism. I want you to understand the adverse effect also. This has an entirely different eye related adverse effect. Reason, this funny channel is present in your retinal ganglionic cells. That is related to your neuron, not the cone cell. Keep in mind, digoxin is the one, the vision, yellow coloring. But ivabradine is cause luminous phenomenon or blurred vision, and it's like a flickering white light they can see. Reason, because it is affecting your funny current or sodium channel in your retinal ganglionic cell. That's it. Then because it is directly blocking the sodium SA node, this is causing bradycardia. Okay. So this is good. Then next is, we already learned, please refer SGLT2 inhibitors in the SGLT2 inhibitors in the diuretic lecture summary in the other video, but just I can mention very quick what are the major things to remember. You're supposed to remember the mechanism of ACAT. Where is it functioning? Easy. In the proximal convoluted tubule, S1 segment has specific sodium glucose transporters there, right? Normally reabsorbed sodium and glucose, right? But when you block it, sodium and glucose will be SGLT. That's why the drug name gliflozin, glucose transporter. Okay, so when you inhibit, it's an inhibitor. Specifically in that S1 proximal tubule area of the nephron, this drug empagliflozin and all the gliflozin drugs can go and bind and completely block the sodium glucose transporters, right? Therefore, you will eliminate a lot of sodium and salt, right? That's very good. That will be very good for what is the special group of population? That is cardiovascular or heart failure with a diabetes, right? If a patient is diabetic, you are removing enough water and additional protection, right? If you add this class of drug, very effective, good drug, well tolerated also, this can be given for regulating sodium and water. Of course, some water will be gone and this extra glucose will be gone. That's also effective, right? So I wanted to study like a special populations like that, right? Like I was talking about elderly patients, African American patients, or no RAS system is activated in this patient, or it is other RAS inhibitors are not tolerant in that group of patients. Heart failure or cardiogenic shock patients, we can use this for a IV drug. Then they're like in the last resort, you can use it. How that drug work, ivabradine just to reduce the SA node activity. You can use it or combined with the other beta blockers. So if it is not effective, only controlled, you can use that drug. So study like that way you will not forget. And last point, because sodium glucose transporters will eliminate glucose also, in some patients, especially elderly patients, they have the risk of UTI risk, okay, urinary tract infection, because glucose is going chance of growing bacteria. Okay, not that important, but it's a good thing to distinguish with the other drugs. Okay, the next one we already discussed very well in your diuretic section. I want you to watch that again, but let me explain very quickly so that you will remember to review all those. How I remember, I always study these 4 drugs together, then I will write it down during my exam and divide into 2 pieces, then I will classify. How do I do? Epileptic spy tried amiloride. That's how I remember. So eplerenone, spironolactone, those 2 are drugs which are aldosterone receptor blockers. These are steroid drugs both, and these are also called specifically targeted mineralocorticoid receptor blocker. Okay, these drugs, both the drugs have additional function or additional mechanism in your heart muscle after myocardia, especially post myocardial patients. Sorry, not myocardial, myocardial infarction. I'm sorry about that. Post myocardial infarction, that is post MI patients. If you can add this drug, sorry, not both, right? Either of this drug, this can prevent fibrosis in your heart. Okay, and that is actually a very good mechanism, right? If you can give this drug, it can reduce the aldosterone mediated. That's an important point to remember, because it is aldosterone. Of course, aldosterone has an effect on your heart muscle, right? So that will be blocked so that you don't get much fibrosis. So it will be slowing down the process because aldosterone is completely blocked. So aldosterone mediated myocardial fibrosis can be blocked by eplerenone or the spironolactone. What is the difference if you are asking? Of course, I wanted to review that also. Spironolactone has a non-specific binding to mineralocorticoid receptor. That's the reason. In addition to the heart muscle, this can also bind and block the androgen receptors. That is sexual adverse effects, right? We will learn in the other mineralocorticoid section also. The spironolactone can cause in male, especially in the elderly patients. It can cause the gynecomastia, etc. But keep in mind, these 2 drugs have additional heart protective. If you are giving both this drug, I will pick the eplerenone. The reason is this drug is with a little more better pharmacokinetics, long acting, and a little more specific target is there is without any sexual adverse effects. Okay, so of course both can cause hyperkalemia because it is blocking the reabsorbing the potassium and eliminating what is the target, where is the site of action. Collecting duct mainly. Think that way so that's easy to distinguish with the other drugs. Okay, same thing, triamterene and amiloride also reabsorb potassium and eliminating some of the about 5% of sodium and water. But what is the distinction? I remember this way. It is those two are non-steroid drugs, and also they are directly blocking the sodium channels in the collecting duct. They are present in the epithelium. That is the reason called ENOC blockers, ENAC blockers, ENAC. What is that meaning? Epithelial ENA, sodium channel blockers. Very good, very good. Okay, so if you have to distinguish those, remember all those and review that other section. Okay, the next one, let's move on. The ninth one is diuretics. Of course, diuretics, what is the major things to remember? Of course, loop and thiazide diuretics are there. Out of the loop, diuretics is commonly called water pills. What is the reason? A lot of water is eliminated with the use of loop diuretics, right? Edema, we discussed in the diuretic section. Please go and watch it again. But let me explain so that you can go ahead and review that again. So I have loop diuretic, 4 different drugs. 3 of them has sulfur MAOT. That's why patients with a sulfur allergy, you should pick the 4th one, ethacrenic acid. But the first 3 drugs are furosemide, torsemide, and bumetanide. I remember like a furious tortoise and bunny went for looping around or went for a run looping with an echidna or ethacrenic acid. Okay, why do you study ethacrenic? All the 4 drugs have same mechanism. Target is ascending limb, target is sodium, potassium chloride, co-transport inhibitor. Very good. When you inhibit, you have 7 components are eliminating. You have to go and review that diuretic section, and also including water, potassium is everything is losing. Similar to that, potassium and water losing and mineral loss is happening in thiazide also. Therefore, loop and thiazide diuretics have a general adverse effect. 2 adverse effects: hypokalemia, because both will eliminate potassium, and metabolic alkalosis, because both will eliminate hydrogen ions or protons. That is why metabolic alkalosis can be higher in this with these 2 type of group of drugs. We were talking about loop diuretics. I wanted to distinguish furosemide, very effective, well tolerated drug, but the problem is bioavailability is less compared to torsemide and bumetanide. Okay, but torsemide has an additional, that's one point to remember. If I have a choice for furosemide and torsemide, later studies proved that torsemide has a better effect on cardiac muscle, an additional effect. What are they? Because torsemide can decrease or reduce fibrosis. It will not speed up the fibrosis. It has an additional effect because of the unique structure. It can reduce the fibrosis. That is an additional protection to cardiomyocyte, okay, especially after MI also, or before MI, this is a protective mechanism. And ethacrenic acid, if a patient is a loop diuretic, what is the one thing? It is good for patients with a sulfur allergy, but it has a unique adverse effect. Of course, keep in mind, all the loop diuretics can cause at some point, especially if you are giving higher dose, this sodium, potassium, chloride channels in the ascending limb of the nephron and your ear. In the inner ear, cochlea can be also blocked. Out of all the 4 drugs, only 1 drug, ethacrenic acid, can easily pass through and enter into our cochlear cells and block that sodium, potassium, chloride transporters. Therefore, in the inner ear, there will be less potassium. It will end up because you are losing a lot of potassium, right? Potassium is important inside your inner ear. Therefore, the cells are going to be suffering. It's going to get the adverse effect, ototoxicity. I remember like ethacrenic, ear is the adverse effect. Ethacrenic acid, ototoxicity. Very good, fair enough. And next, let me finish as soon as possible, okay? So, review that previous diuretic lectures, okay? And the last point is about the thiazide diuretics, okay? In thiazide diuretic, what are the 2 things to remember? 2 major 4 drugs are there. Out of that, typical thiazide diuretic is a hydrochlorothiazide, most commonly used drug and comparatively well tolerated. but very effective and very strong action on potent action is with the thiazide-like diuretic called chlorthalidone. Very strong drug. Okay, there is two different drugs. Other drugs are there. That will be indapamide and metolazone. Metolazone is usually used for diuretic resistant patients, but indapamide, that is included in 2025 ACC AHA, American Heart Association updates. So therefore I wanted to study that also. Indapamide can be effective. Reason, especially in the elderly patients, this will not have additional metabolic adverse effect. That's a super important point. Why? That's what you need to go ahead and review that 3 points. Thiazide diuretic, hydrochlorothiazide and chlorthalidone has effect on our pancreatic beta cells. Okay, so because of their unique structures, they can easily get into the pancreatic beta cells and block the sodium chloride cotransporters in the distal, similar to distal convoluted tubule inhibition. Similar inhibition can happening in our pancreas. Therefore, our insulin secretion will be very low. Therefore, patients can get secondary hyperglycemia. That's a super important point to remember, because I wanted to remember 3 different things in the thiazide diuretics. 2 major drugs, hydrochlorothiazide and chlorthalidone. 3 major points are how it is protecting the osteoporotic patient. So if a patient has osteoporosis, why is, if I have to pick a drug, pick a diuretic, I don't pick loop diuretic, I pick thiazide. Reason, thiazide diuretic can reabsorb calcium. They will not eliminate calcium, right? Remember that point. So that's why it will be very effective, especially elderly, right? Patients, women, and all the patients, whoever need more extra calcium. Oh, it is reabsorbed. Very good. And the last point, if a patient has a history of renal stone, which is made up of calcium oxalate or calcium phosphate deposit, and if you have to, it's like a precaution, right? Prophylaxis, you don't eliminate too much calcium into the urine. Therefore, the reabsorption will be good for the as a preventive mechanism. And the third point is, I told you, that's an adverse effect. Why patients treated with a thiazide diuretic can get hyperglycemia. Reason is because losing potassium inside the beta cells of the pancreas, not with loop diuretic. Keep in mind, only thiazide diuretics, because of their unique structure, they can easily get into your pancreas and inhibit insulin secretion, affecting the beta cells, because potassium is so important for secretion. That's all you need to remember. Secretion in beta cells and also in the SNR cells. Okay, that's why. Okay, stop right there. I wanted to compare here the potassium effect with the other drug we were talking about, digoxin. Remember the visual yellow color? Potassium has a role because there is less potassium there. That is entirely different mechanism. We learned that with another drug we learned in hypertension drug. Look at the hypertension review that has minoxidil, right? Remember minoxidil? Why is it very effective to increase the hair growth also? Reason, the mechanism of minoxidil is opening potassium channels. That means cells will get more potassium. So keep in mind, just opposite to this, they are not losing potassium. Minoxidil will increase the potassium in the smooth muscles and provide a lot of blood circulation, because relaxing the blood vessel, providing a lot of blood circulation into the at the base of the hair follicle. That's why, just go ahead and review that topic also. And then let's move on. And now to the ACE inhibitor, enalapril, right? ACE inhibitor, I wanted to remember, we already learned in the hypertension, lisinopril and ramipril, right? Captopril, I'm going to teach you again in the antiarrhythmic, I believe. And the ACE inhibitors in the enalapril is the best one here. Reason, I wanted to study one drug, but all the prils have class effect, adverse effect. Remember, dry cough and angioedema, I explained very well in the previous summaries, so I wanted to watch that. But understand, enalapril is a gold standard ACE inhibitor in patients with a heart failure. Reason, trials, most of the trials shows that better side effect profile because of its longer duration and the duration of action, and the fewer daily losses, and also pharmacokinetics better compared to the other drugs. And enalapril, well told, it's a pro drug. If somebody asks you enalapril, the metabolite is enalaprilat, that is the drug, a new drug coming into the market. That's an IV drug, very effective, very good drug that is good for hypertensive emergency, in case if you wanted to connect it, okay. But keep in mind enalapril and captopril, of course. But if you wanted to remember to distinguish, captopril has a unique mechanism because it has a tendency to, because of the structural shape like sulfahydryl unit. Don't worry about it. Captopril structure have an ability to bind with the zinc ions in our saliva, especially in your taste buds. Therefore, the patient usually get like a loss of taste. In case if you are wondering, the prils with that group will have that adverse, but enalapril doesn't have. What do you have to memorize for major pril adverse effect? 2 common adverse effect: dry cough. Of course, I explained that. Watch that video. And the other adverse effect, angioedema. Why angioedema is super important? That is rare, but that is a life-threatening adverse effect. That's also. So remember, both are important. And the last one, we are done. And angiotensin receptor blockers. Okay, so we already learned in the previous hypertension lecture, losartan and handesartan I mentioned. Valsartan we learned here. Look at it, valsartan here. Sacubitril valsartan, that's an angiotensin receptor blocker combined with a neprilysin inhibitor, always coming together. So you study that together. But it is an independent drug angiotensin receptor blocker, that is, it may be losartan or valsartan or candesartan. All this sartan works by mechanism of action, easy. It is an angiotensin receptor blocker in the RAS, renin-angiotensin-aldosterone system, early stage. Keep in mind, angiotensinogen supposed to convert into angiotensin 1, that is blocked by the renin inhibitor, right? Aldesleukin. Okay, but angiotensin 1 supposed to convert into angiotensin 2, that was blocked by ACE inhibitors, right? That enzyme will be blocked, therefore bradykinins increase, all the adverse effect. But angiotensin 2 supposed to angiotensin 2 supposed to go and bind and block angiotensin 1 and stimulate, that is AT1 receptors, right? AT1 receptors on the vascular smooth muscle, so that you're supposed to contract the blood vessels and increase the blood pressure, right? That's why we are producing angiotensin 2 in the body. That's why the receptors are called angiotensin 2 receptors or angiotensin type 1 receptor, AT1 receptor. So that function is blocked by angiotensin receptor blockers. Okay, I explained that in the hypertensive lecture. That's why I wanted to watch that. Okay, let me finish this so that you don't want to feel that this is a 2-hour lecture, right? So I wanted to finish before an hour. Okay, last point, other drugs, right? I don't want you to memorize too much because vericiguat is a new class of drug you may see in future. That's why I wanted to remember. Soluble guanylate cyclase stimulator. Reason, if somebody asks you, normally when the failing heart will have like a less nitric oxide. Okay, cells are weak, right? Your endotheliums are not functioning. Therefore, your body, if you are giving an artificial drug, right, vericiguat, this is going to bypass that and stimulate soluble guanylate cyclase so that you get enough nitric acid level and also to just dilate the blood vessels. That's why you are giving. The last one is for cardiac failure or cardiac arrest, right? Remember, in emergency department, usually look at the clinical lectures. Epinephrine you will give. Reason, it will be really quick acting, right? Like alpha-1 activation, so that coronary perfusion will be high. That's an IV drug, okay? And if anybody asks you why dopamine is not falling out of favor, if anybody asks you, the reason is we have dobutamine. Dopamine has a multiple receptor, right, activation, especially dopamine was a D1, D2 receptor agonist, but beta one agonist also, but they keep in mind it has a more adverse effect, like a risk of arrhythmia and myocardial oxygen demand is too high if you are giving dopamine, but compared to dobutamine IV for an emergency situation, very short half-life, we can can do controlled and predictable pharmacokinetics for dobutamine. That's why we prefer. That's why I didn't include dopamine here, but if you like, you can study with that. And this is it. That's it. I think I mentioned everything. Hope this is helpful. Thank you.